Welcome to the general principles of antimicrobial chemotherapy. This is the second part of our lecture. In the previous part, we had a small introduction to the general principles of antimicrobial chemotherapy. And today, we are going to discuss some clinical aspects related to this topic. So, an infection. So, an infection is when a pathogen establishes itself within the host. After establishing, it replicates and it harms the host. And it also causes a host response. Okay, so that is infection. An infectious disease, is when this pathogen gets transmitted and cause the disease in other hosts. Okay, so that is an infectious disease. So an infectious disease, there is a pathogen that can be transmitted to other hosts to cause the disease. Okay. So the pathogen itself, this pathogen itself, when it causes an infectious disease, is called an infectious agent. Okay? The definition of what exactly is an infectious agent is given by Koch's postulates. Okay, Koch being the eponym of the famous microbiologist Koch. Okay. So what are his postulates? The postulates is, there are basically four of his postulates. The first one is that every disease, meaning every case should have the same microorganism. Okay. The second postulate is that the organism must be isolated and cultured in vitro. Okay, so every disease should have the same microorganism, and this microorganism must be isolated and cultured in vitro, meaning outside the organism. The third postulate is that isolates from this in vitro, isolates from this in vitro, okay, when inoculated into a healthy susceptible animal, should cause the disease. And the fourth postulate is that the organism must be re-isolated from this diseased animal. Okay, should be re-isolated from the diseased animal. Okay, so if there is an organism that satisfies these conditions, okay, if there is an organism that satisfies these conditions, then that is an infectious agent. Okay, so that eliminates other things that we might potentially consider an infectious agent. Okay. All right. So let's consider there is an infectious agent. Let's say there is an infectious agent, and this infectious agent enters into a susceptible host. Okay, and this host can be a reservoir. And from this reservoir, the infectious agent could be transmitted. Okay, thereby they exit the host. Okay, they exit the host, and they become again the infectious agent, which can potentially infect other hosts. Okay, so let's review. There is now an infectious agent which we have defined above, and that infectious agent gets into a susceptible host. So what is a susceptible host? A host in which this infectious agent can establish itself and then cause an infection. Then that infection in turn becomes a disease. So this infected host now becomes a reservoir in the community, and from him or her, it can be transmitted by different ways, and it can affect other susceptible hosts. Okay, so this is called a chain of infection. Chain of infection. Okay. So if our goal is to treat an infectious disease, then what we can do is we can interfere with the chain of infection. Okay. So if we break the chain of infection, we can reduce the incidences of the disease. Okay. So there are different ways in which we can break the chain of infection. We can have an intervention at the level of the susceptible host. Okay. So by definition, a susceptible host is someone who can be infected. Now, if this susceptible host, if we can increase the immunity, okay, what do? We increase the immunity. Then what happens? This host becomes less susceptible. So even if there is an infectious agent that is coming, because of the host having immunity, it won't be able to establish and cause a disease. So how can we increase the immunity? We can if you said vaccines, you're absolutely right. So we can increase the immunity by administering vaccines. Yeah. Or what can we do? We can intervene at the reservoir. So reservoir, again, the reservoir itself can be an environmental reservoir, it can be a host. Okay. The reservoir can be environmental. They can be animals, or they can be hosts. Okay, so these are all reservoirs. Let's take an example. Suppose there is plague. And this plague, what is the causative agent? Yes, pestis. Okay, it's transmitted by, yes, rats and rodents. Okay. So these rats are the reservoir for plague. This is Kernicterus humans. Okay. So in the environment, the rats are the reservoir and humans become the host. So if we can eliminate rats, then we potentially stop the Yersinia pestis getting into humans. So we can interfere at the level of the reservoir. Okay. And the mode of transmission. Okay. So there are different modes of transmission. What would be the different modes of transmission? Let's say by the respiratory route. Okay. When someone coughs or sneezes, there are droplets, and it can be transmitted through the respiratory route or the fecal oral route. Okay, fecal oral route, or they can be sexually transmitted. Okay, so depending on the sexual practice and the orientation, there are different methods by which it can be sexually transmitted, or it can be blood-borne. Okay, so maybe it's a malarial parasite in the blood, and another mosquito comes, drinks the blood, and transmits it elsewhere. Or it could be maybe by transfusion. Okay, transfusion of contaminated blood could potentially transmit a microorganism. Or there can be maybe direct contact. Okay, direct contact, it can be spread. Then it can be spread by fomites. So what are fomites? They are basically non-living things which, if contaminated, can potentially spread the disease to other hosts. Okay, so fomites. Sometimes they can be spread deliberately. Okay, so put it in another color. Deliberate spread. Okay, does anything come into your mind? If you said bioterrorism, you're absolutely right. Okay, so bioterrorism, you can deliberately spread, like say anthrax, okay, or other genetically modified organisms. You can deliberately spread. The other one could be healthcare associated. Okay, you don't have a disease, and by chance you get a disease, and to treat that you get into a healthcare setup, and because you stepped into the healthcare system, healthcare setup, maybe there was a microorganism in the hospital which got into you. So that is what we mean by healthcare associated spread. Okay, so it can be transmitted. By transmission, it basically exits the reservoir. Okay, so there can also be vectors. Okay, we took the example of plague, so it can be spread by vectors. Okay, so vectors are basically the intermediate. For example, the rats that spread plague to humans. So rat could be a vector. So vectors can also spread. So we can also, so if our goal is to stop an infectious disease, what could we do? We could interfere at the mode of transmission. Okay, so let's take the example of the current COVID-19. Okay, that color is not very clear, so we'll use different. Okay, so COVID-19 infection. So how do we prevent the spread? We try to use a mask. Okay, there is a N95 mask. Okay, so let's assume this is a mask, and the person is, this is the mouth of the person here, and this is the mask. So this N92, what does it do? It prevents the exit of the microorganism from the infected person to outside. Okay, and it also prevents the entry. Okay, so both these things are blocked by a N95 mask. What about other masks? So you use another mask. Okay, the one which everyone commonly is using nowadays. So this mask, it prevents an infected person transmitting it outside. Okay, so the idea is, ideally in an ideal world, if everyone has a N95 mask, that is the best, but this mask is kind of expensive. So then why is this one being preferred and advocated? The reason is, if everyone uses masks like this, okay, so what happens? Let's imagine both of them have got the COVID-19 infection. Okay, so this person, because he has a mask, he won't be able to spread it outside. And this other person, maybe he doesn't have infection. He won't be able to, if he is also infected, he won't be able to pass it on. So if everyone begins to use a mask, then we can effectively prevent the transmission. Okay, so here what are we trying to do? We are saying it is spread through the respiratory route, and this is our intervention arm. We are using a mask. Okay, so similarly, with the mode of transmission, we can interfere in all these areas, and we can prevent the incidences of an infectious disease. Okay. The other thing that we could do is we could target the infectious agent. Okay. So in our lecture today, we are going to focus here. This lecture would be focusing on the selection of antimicrobials. Okay, so the general principles involved in the selection of antimicrobials. So this is the topic that our lecture today is going to focus on. So this is just one part of the intervention in breaking the chain of infection. Okay, so this is also the limitation of our lecture. Okay, we won't be talking about the other aspects. Okay, we'll be focusing only on this aspect. Okay. So let's write it down here exactly what we're going to focus on. We're going to look at the drug selection process. General principles. Okay. Drug selection process. What drug are we talking about? We are talking about antimicrobial. Okay. So basically we are talking about small molecules which are involved in the treatment of infectious agents. Okay. So the drug selection process, we can break it down into 5 stages. Okay. So the process, we can break it down into 5 stages. Okay. And the first stage is deciding if the antimicrobial therapy is warranted. Okay, in other words, should we start an antimicrobial therapy? Okay, so that's the first step that we need to address. The second is to identify the pathogen. Okay. The third stage would be to institute empirical therapy. stage would be to assess the instituted antimicrobial therapy for assess the instituted antimicrobial therapy for efficacy and toxicity. And the fifth stage would be to refine the instituted therapy. Okay. So these are the 5 stages that we are going to discuss in some detail. Okay. So the first one is to decide if the antimicrobial therapy is warranted. Okay, so what do we mean? Should we start treating with antimicrobials? Okay, so that is the question that we are going to address now. Okay. So, which brings us to another question. What if we don't? What if we don't start antimicrobial therapy? Okay. So we ask the question, should we start treating with antimicrobial therapy? And we get an answer, yes. Okay, having that answer yes in mind, we ask ourselves, what if we don't start the antimicrobial therapy? What could be the complications? So the complications is that if we don't treat a warranted disease, then what could happen is there can be complications. Okay, and these complications may be mild to it may be life-threatening. Okay, if the person goes into septic shock, then the person may probably die. And studies have shown that intervention with antimicrobial therapy is associated with reduced mortality and morbidity. Okay. So if we treat, what will happen? We can reduce morbidity and we can reduce mortality. Okay. Morbidity meaning functioning, okay, a change in our functioning. And mortality is obviously death. So this is the reason why we need to treat diseases based on our assessment with antimicrobials. So let's get back to the question. How do we decide whether we should start treating with antimicrobials? Okay, so let's look at that patient. Let's say there is a patient with a patient coming and complaining. Say, let's write it down here. There is a patient, we'll call it a client. We'll call the patient a client, so because we are healthcare providers, they are our client. So the client comes and says that onset. Okay, infection. It says he has got this infection for, maybe 3 days. Okay. And you ask, what is your chief complaint? And the patient says, I've got lots of complaints. I've got fever. Okay, and this is a mild fever. Okay, I have had severe fevers in the past. This is not that much, so I consider it mild fever. And I have a sore throat. And I have a cough. Okay, and there I've got a congestion in my nose. Okay. The nose, I've got a little bit of difficulty breathing. And I feel very tired. I've got, fatigued. I'm fatigued. I'm not able to do things. And then I've got lots of aches. Okay, specifically I got body aches. And I've got maybe headache. I've got headache. Okay, I've got headaches. And I've got a loss of appetite. And there is some changes with my voice. Okay. My voice has become hoarse. Okay. And you ask this patient, okay, what type of a cough you have, and the patient says, I've got a productive cough. There is sputum. And then you ask the question, is there any change in the color of the sputum? And the patient says, no change. Okay? Right. So this information leads you to you assess the patient, and then you're left with no doubt that it is a viral infection. Okay? Okay, so it's an acute viral infection. Now, an acute viral infection like this, there is no need for a treatment. No need to treat the disease. Okay, because it is self-limiting and self-resolving. Okay, provided the patient has got a functioning immune system. Okay, so what do you need to do then? Well, you're not going to treat the disease, meaning you're not going to treat, say, this is a rhinovirus infection. Okay, so you're not going to give an antimicrobial drug. Okay, so then what do you do? Well, the patient obviously has got a problem. Then what do? You treat the symptoms. Okay, so in this case, the patient has got fever, so you give an NSAID. Okay, maybe it's got a stuffy nose, so you give something that can relieve a stuffy nose. You can give a nasal decongestant. Okay, so the patient is having, maybe you can, they can have a post-nasal drip, and so you can give an antihistamine. Okay. So with this, you can manage the infection. Now, if the patient is having, maybe you can give an antihistamine, and so you can give an antihistamine. Okay, symptoms. Okay, so this is one case where you needn't give a antimicrobial agent. Okay, so you know you don't give a antimicrobial. What if there is a change in the sputum and the fever is severe? Okay. Then maybe that is a bacterial infection. Then that needs to be looked into. So we need to assess the patient. Okay. All right. So up till now, what are we talking about? We are talking about the first decision that we have to take. We have to decide if there is a need for antimicrobial therapy. Okay. So in this case, we said that the first situation is we don't need to give an antimicrobial agent. Okay. So we need to pay a good deal of attention to the chief complaint of the patient. So the chief complaint, okay, of the patient. If we pay attention to the chief complaint, then we can localize the infection to organs, okay, to the organ that is infected. Okay, so if the patient says, I've got difficulty in urination, then we know that it is a urinary, it might be a urinary tract infection, and that gives us a clue. If it's a urinary tract, maybe it's a gram-negative organism. Okay. Or let's take some other examples. So, if suppose the patient complains of an upper respiratory tract infection, then probably the it's a chronic infection of the lungs, in which case the causative, if it's the lung, the causative organism could be maybe Streptococcus pneumoniae. Okay, or it could be what? Haemophilus influenza. Okay, or it could be Staphylococcus aureus. Or if it is, maybe the patient says, I'm having this cough for the past 2 months, then we could suspect that it's a chronic infection, in which case we would be suspecting Mycobacterium tuberculosis. Okay. So if it's the throat, then if we could observe the throat and we find spots, then it might be Candida, or it can be strep throat, it can be Streptococcus. Pyrogens, or it can be, if it's hospital acquired, then it could be MRSA. What is MRSA? Methicillin resistant Staphylococcus aureus. Okay, what's the drug of choice for MRSA? Yes, vancomycin. Okay, or it could be viruses. Okay. And so, as we said, if it's kidney or the bladder, So the point is, if we listen to the chief complaint of the patient, we can localize the organ to which where there is an infection, and that gives us a clue to the probable organism that is causing the disease. And if we have a clue to that, then it can guide our selection of the drug. Okay. Then we need to take a proper history of the patient. Okay, so comprehensive history, which could cover things like in between we could do a review of the systems. Okay, we could examine the patient and do a review of systems. And we can take a proper history. We ask, what's your past medication history? Okay. And so, the past medication history would give us, we can ask about if the patient has undergone any surgical procedures or has gone to a dentist. They had previous infections, or they're currently on maybe NSAIDs, in which case, they might not be having fever when we talk to them. Okay, so yeah, so the past medical history helps. And we can also look at the medication history, as we previously said. If they are on NSAIDs, then that we might not be able to elicit the sign. And we can ask them about their allergy. Okay, that can help us guide the therapy. Suppose they are allergic to penicillin, then that might not be a good drug to be selected. And we can ask them about the family contact history, Okay, so ask them about if they are having maybe HIV or TB, then those can be issues. Then travel history, yes. Okay, so in the recent past, if you have traveled to China, then you're subjected to detailed history questioning, in these days when we have COVID-19 infection. We could ask them about their occupation. Okay, so if they are working in the leather industry, then they can be susceptible to a particular type of microorganisms. Ask them about their recreational activity. If they are into water sports, then there is likelihood of them being affected by some specific microorganisms there. Animal exposure, whether they got a pet. Sometimes they may have worm infestation from the pet, right? Or we could ask them about lots of other things like their dietary history. Okay, whether they have consumed raw meat or raw fish, sushi, which makes them so they might have some infections connected to that, and whether they are if they have a history of intravenous drug use. Okay, so that again puts them at risk for infection. Talk about their sexual history. Okay, that could also give us a clue. And their vaccination history. Okay, so a properly taken history can point us to clues regarding the causative organism, which in turn would help us to choose the drug. Then what could we do? We could use some tests. Okay, we could use some tests to diagnose the infection, if any. Okay. So what tests? We could have non-specific tests. Tests for what? Inflammation or infection. Okay. Like we could have complete blood count, we can have a differential count, or we can have a C-reactive protein, okay, which are elevated in inflammation or infection. We could do procalcitonin. Okay, so this is one of the emerging markers because it is elevated in inflammation or infection. Okay, or cell count could be done in the urine or the CSF. Okay? And CSF protein or glucose could be estimated in the CNS. Or what else could we do? We could do direct detection of the microorganism using microscopy. Both dark field and wide field electron microscopy can be done. For example, COVID-19, we can, tissue biopsy samples can be subjected to electron microscopy, and we could, see the virus as such. Or we could use an antibody test to detect the antigens. Okay. Or we could use nucleic acid amplification tests, okay. PCR. Okay. So if you got the primers for the specific disease that you suspect, then using PCR you can see whether this person is infected by that particular organism. Or you could do culture and sensitivity. Okay, but the problem with this is that the results are not obtained immediately. It will take some time. So this is not the first thing that you could do. So the things that you can get a rapid result, you do it at this particular stage of your stage. Or you could do specific antibody tests. Okay. Or interferon gamma release assays. Okay. Interferon. So specific tests can be done. All right. Okay. All right. So what about WBCs, which is the kind of test that is commonly relied upon? WBCs. Let's say we got a WBC differential count, and we have a differential count of this. How can this help us? All right, so any idea? Okay. Any idea about how WBCs and differential count can help us? Okay, so let's talk about that now. So we have got blood cells. Blood cells can be WBCs, they can be RBCs. Okay. And WBCs, how do we classify? We classify them as A granulocytes and granulocytes. Okay. So what are the granulocytes? We have three: basophils, eosinophils, and neutrophils. Okay, which are most abundant? It is the neutrophils. Okay, and what are the granulocytes? We have lymphocytes and monocytes. Okay, so what is the normal WBC count? The normal count would be WBC count would be 4,500 to maybe 11,000 cells per millimeter cube. Okay. Yeah, so that's the normal range. So if there is, if the peripheral blood count increases, then we can suspect an infection. So sometimes it goes up to 30,000 to 40,000 cells per millimeter cube. Right? So if we do microscopy, then we see that if we we try to count the WBCs, in case of bacterial infections, when we count the WBCs, we can observe immature cells and mature cells. Okay, and when we report from immature cells to mature cells. So immature cells and mature cells are same. These mature cells, they have got a segmented nucleus, so we call them segs. Okay, and the immature cells, we call them bands. Okay, so immature cells, we call them bands, and mature cells, we call them segs. So if there is a bacterial infection, then there is, I told you, we just said that when we count, we look from immature to mature. So when we count and we see that there is more of immature cells than mature cells, we say that there is a left shift. This is called a left shift, where there is more immature cells than mature cells. So this is called a band shift. Okay, so a band shift, if it is seen, then it is it gives us an idea that there might be an infection. Okay, so immature cells, a left shift, a band shift, which tells us there is a bacterial infection. Okay, but when we see a band shift, we should also be aware that there are other things that can cause a band shift. For example, steroids. Okay, they can cause a band shift. Cancer can cause a band shift. Maybe things like myocardial infarction, surgery. Okay, these things can also cause a band shift. Okay, so these things should be eliminated when we try to interpret a WBC count. Okay. So then we got to look at whether the patient is actually showing certain symptoms. Okay, what could be the symptoms? Symptoms and signs. person is having, say, fever, signs of inflammation. Okay, so these things we observe when we actually examine the patient. Okay, so let's look at fever. Okay, so fever is usually the hallmark of infection. Okay, it is the hallmark of infection. So let's look at what is fever. So what's the normal body temperature? So the normal body temperature is basically a range. It is 36.7 to 37 degrees Celsius. Okay. So this, though it is a range, we normally, when we say a normal body temperature, we say 37 degrees Celsius, and that is 98.6 Fahrenheit. Okay, so this is the normal body temperature. Okay, so if the temperature increases greater than 38 degrees Celsius, okay, we call it fever. Okay, so what is the fever due to? A fever is usually due to pyrogens. Okay. Pyre meaning fire. So the things that can heat up the body. And these pyrogens can be exogenous or they can be endogenous. Okay, exogenous is, say, the gram-negative organisms. They have got a cell wall that has got lipopolysaccharide. So lipopolysaccharide is a pyrogen. Okay. And what are endogenous ones? Endogenous ones usually the hematopoietic system produces certain cytokines. Okay, like what? Interleukin 1, interleukin 6, tumor necrosis factor. Okay, so these are basically the endogenous pyrogens. So endogenous pyrogens are usually cytokines. So all these things, both the endogenous and exogenous pyrogens, can reset the set point in the hypothalamus. Can reset the set point of the hypothalamus. Okay, so the hypothalamus basically controls the body temperature. Okay, so if you reset the hypothalamus at a higher setting, so normal is say 37 degrees Celsius. If that is set to 39 degrees Celsius, so what happens is the body tries to increase the temperature to 39 degrees Celsius. So how does it do that? By bringing about changes in the skeletal muscles, so we can have rigors or chills. Okay, so that basically the skeletal muscle begins to contract, and then if it contracts, it generates heat, and that heat, skeletal muscles are supplied with lots of blood vessels. So that heat gets transferred to the blood vessels, and then blood in the blood vessels get heated up, and ultimately your body temperature rises to the new set point. Okay, so yeah. But the problem is, fever, though it is a hallmark of infection, there are other things also that can cause an increase in, there are non-infectious causes of fever. Okay, so one of the most important non-infectious cause of fever would be, say, malignancy. Why? Because malignancy, there will be lots of endogenous cytokines which can increase the temperature, but it is not an infectious cause, or maybe autoimmune diseases. Here again there is increase in the endogenous cytokines, in that it's not an infectious cause. Can also be caused by drugs. Certain drugs can cause fever. Okay, so what drugs? Drugs like monoamine oxidase inhibitors. Okay. Could be the examples could be imipramine, yes. Imipramine, there can be amitriptyline, can be nortriptyline. Okay, so these are monoamine oxidase inhibitors, then tricyclic antidepressants. Like imipramine, amitriptyline, nortriptyline, and there can be what? Amphetamines. Okay, so if the person is an illicit drug user of maybe phencyclidine, LSD or cocaine. Okay, so these are illicit drugs. So if the person is an illicit drug user, then that can also be a non-infectious cause of the fever. So when someone presents with a fever, these things need to be eliminated and need to know whether it is caused by infectious agents, and only then it has to be managed with an antimicrobial agent. Okay. So these are the most important aspects that we should be looking at when we try to discuss the first point here. What was the first point? Deciding if the antimicrobial therapy is warranted. Okay, so this is what we have been discussing until now. Okay, so which brings us to the second one. Yes, what is the second one? What is the second one? Identifying the pathogen. Okay, so now we are going to discuss aspects of identifying the pathogen. Let's bring it somewhere so we get some space for writing. Okay, so identifying the pathogen. So we did the preliminary things, we did the primary tests, okay, and we have come to the conclusion that it is an infection for which an antimicrobial drug needs to be selected. So now the question is about identifying the pathogen. Okay. So depending on the location, we need to collect some specimen. Okay. Specimen needs to be collected. Okay. So this specimen depends upon the site. Depends on the site of infection. Okay, so what are the different specimen that is collected? It can be sputum. Okay, what else can it be? It can be urine. Okay, it can be CSF, cerebrospinal fluid. or it can be stool, okay, or it can be wound swabs, okay, wound swabs, throat swabs. Okay, so these are the specimens that can be collected. So what about blood? Yes, blood can be used, but the problem with blood is you need a large volume, about 20 ml is required um, to culture an organism from blood. So therefore, though we can theoretically use it, this is not the preferred body fluid for specimen identification. Okay. So after all this, specimen is collected, what is being done? This specimen is cultured. Okay. After culturing, it is isolated and then it is subject to identification tests. Okay, so what are the identification tests that we are going to talk about, we are thinking about? It could be, we could do gram stain. Okay, if it is a mycobacterium, what can we do? We can do an acid-fast stain. Okay, then we can culture it under aerobic or anaerobic conditions, so we get an idea whether the organism is aerobic or anaerobic, or we can do nucleic acid amplification tests, which we initially told the PCR can be done. Okay, in these ways we can identify the organism. So with this specimen, what do? We do a culture. Okay, why do we do the culture? For identification. And the second thing that we do is we do a sensitivity test. What is a sensitivity test? It is saying the susceptibility to antibiotics. Okay, so culture and sensitivity test is done with the specimen. Okay, so the specimen is subjected to culture and sensitivity test, and the susceptibility to antibiotics is found out. So how do we do that? There are different methods, like the dilution method, which you have studied in microbiology. And we could also do disk diffusion assay. Okay, what is this method called? It's also called the Kirby-Bar method. Okay, and so disk diffusion assay, the dilution assay can be done. Okay, so nowadays there have been advances. There are commercial tests that can be done, like the E-test, okay, which is basically a strip containing the antimicrobials in different concentrations that is put to a culture plate. And what information can we get? We can get the MIC, okay, minimal inhibitory concentration can be obtained, okay, using this E-test. And there is also automation of this. Okay, so most of these methods are very time consuming and tedious. So there has been automation. What are the examples of automation? There is this company that has come up with a test system. It's called White Tech. Okay. White Tech system. Okay, where you can do the identification as well as sensitivity test can be done by this system. And there is also another by another company, which is the BD. You know what is BD? BD Phoenix. It's called Phoenix automated microbiology system. Okay, so this is the recent automation, okay, which reduces the time for your result to come. Okay. So now you have given it for culture and sensitivity. Okay. Now what do? We institute the empirical therapy. Okay. So empirical. Okay. So what does empirical mean? Empirical basically means anything that you obtain by your observation and experience. Okay, so empirical is there has been lots of clinical observation and there has been lots of clinicians who have experienced in treating different types of infections and they have reported it, and that body of knowledge is basically utilized for empirical to select empirical drugs for the treatment of these infectious diseases. Okay. So empirical drug therapy should be immediately instituted if the infection is determined to be life-threatening. Okay, so what are the examples of life-threatening infections? The examples could be febrile neutropenia, okay, meaning there is less of neutrophils and there is fever. Sepsis. Okay, sepsis. What is sepsis? When the bacteria begins to grow uncontrollably within the blood. Okay, and the body reacts to the toxins that is produced by these microorganisms. Okay, so that is called sepsis. And bacterial meningitis. Okay, this is infection of the CNS. Then there is CAP. What is CAP? Community acquired pneumonia. Okay. There is also ventilator associated pneumonia. Okay. There is a very, very severe condition called necrotizing fasciitis. Okay. So these are life-threatening infections. So the samples, the specimen should be collected from these patients as soon as possible, and they should be immediately administered the empirical therapy, which is basically broad spectrum antibiotics. Okay. Spectrum broad spectrum antibiotics should be administered. Okay, sometimes combination of antibiotics should be given in this particular conditions. Okay. In other patients, a little bit of time can be taken, and references, like what are the references? References like published papers, guidelines, antibiograms, resources like the Sanford guide can be consulted to guide empirical therapy. Okay, can be used to guide empirical drug selection. Okay. The point to remember is this empirical drugs that is selected should be tailored to the individual patient. Okay, so this gives general information, and that information should be used in conjunction with the situation of the individual patient. Only then it should be administered. Okay. So when we tailor it to the individual patient, we should be aware that there are drug factors and patient factors that needs to be taken into consideration before a drug can be selected. So what are the drug factors that we are talking about? Factors. The important drug factor would be the site of infection. Okay. So the drug should access the site of infection. Suppose the site of infection is the CNS. Then the drug that we select, it should cross the BBB, the blood-brain barrier, and reach the CNS, meaning this drug should be highly lipid soluble. Okay, only then can it penetrate the BBB and reach the CNS. What is the example that we can give of penicillin? Okay, penicillin normally does not cross the blood-brain barrier, but in meningitis, the BBB becomes permeable to penicillin. Therefore, in meningitis, one of the drug of choice is penicillin. Okay. What are the other drugs that can easily reach the CNS? We have got aminoglycosides. Okay, like what? Gentamicin, nettlemycin, amikacin. These drugs can easily reach the CNS. So this would be the first drug factor that we are talking about, this site of infection. The other thing that we have to know is, suppose there is an abscess. Okay, so what is abscess? There is a collection of pus. Okay, so this pus needs to be drained. Okay, only then will the antibiotic reach that particular site in effective concentration. Okay, so site of infection. The other thing that we need to look as a drug factor is the mode of administration. So if the infection is severe, then oral is not the best route because it takes time for it to reach the compartments in any significant, in high concentrations. Okay, so the best choice would be giving it by a parenteral route like IV or IM, okay, intravenous or intramuscular. Okay, so let's look at some patient factors. Okay, so patient factors. Do we have space here? So let's bring it down here. Patient factors. Let's take okay, let's consider the first patient factor, which would be, what's the most important patient factor? It would be age. Okay. Age, let's consider neonates. Okay. Or maybe premature infants. Okay, so these patients, if they get infections like meningitis or maybe plague, okay, or cholera or typhoid. These are all infections which are very common in pediatric, premature and neonates in India. Okay. So the drug of choice in this case is chloramphenicol. Okay, so chloramphenicol itself is broad spectrum. What is broad spectrum? Yes, effective against both gram-positive and gram-negative. And it is bacteriostatic. Okay, so chloramphenicol is broad spectrum and bacteriostatic. What's the important adverse effects of this drug? The important adverse effect is it can cause hematological conditions like agranulocytosis. Okay, so that's hematological complications are one of the important side effects of this drug. Okay, so what's the mechanism of action? The mechanism of action is that it interferes with protein synthesis. Okay, so it inhibits what's that enzyme? Peptidyl transferase. Okay, peptidyl transferase activity of bacterial ribosome. Okay, so as a result, what happens is it prevents protein chain elongation. Prevents protein chain elongation. So that is the problem with this. I mean, that's the mechanism of action of this drug. Okay. So why are we discussing this drug? Because in neonates, okay, in premature infants or neonates, these patients, chloramphenicol may cause something called a disease called gray baby syndrome. Okay. What is syndrome? Syndrome is a collection of symptoms. And what collection of symptoms are we talking about? So syndrome is a collection of symptoms. Okay, so what are we looking at? There is gray discoloration of skin, especially the lips and the skin in general. So because it's a small in size, it becomes very apparent. Okay. And there is decrease in body temperature. There is vomiting. Collection of signs and symptoms. Okay. There is vomiting, and there are cardiac abnormalities. Okay. What cardiac abnormality? Decrease in myocardial contraction. Okay. So yeah. So gray baby syndrome is this. Okay. So we have seen causes gray baby syndrome. So now the question is, why does it happen? In infants or neonates? Okay. So the answer is that adults, let's say they have a normal liver function, okay, in adults or people with a normal liver function, what happens is chloramphenicol is converted by an enzyme, an enzyme called UDP, glucuronide transferase. Okay, transfers glucuronide to chloramphenicol, making it chloramphenicol glucuronide, and this is water soluble and it is excreted. Okay. So in infants and neonates, their liver is not matured. As a result, this pathway is not very effective. As a result, they don't produce chloramphenicol glucuronide, which means they don't excrete chloramphenicol glucuronide. So then what happens is chloramphenicol, as a result, chloramphenicol accumulates. Okay, so if it accumulates, what happens? What does it do? It blocks the electron transport. Electron transport in the liver cells, the myocardial cells, liver cells, the myocardial cells, and the skeletal muscle cells. Okay, so the liver cells, if the electron transport is blocked, what will happen? There will be liver dysfunction. Okay, the myocardial cells, what will happen? There will be decreased contractility. Okay. This decreased contractility can lead to, if these myocardial cells don't contract, what will happen? They won't be able to pump blood. So if they don't pump blood, there will be hypotension. Now, if there is no blood being pumped, what will happen? There is no oxygenation, and if there is no oxygenation, there will be cyanosis, which is the bluish discoloration. That is characteristic of Gray baby syndrome. And in skeletal muscles, what will happen? The skeletal muscles will become flaccid, okay, meaning they will lose their tone. Right? So that is the reason why chloramphenicol causes Gray baby syndrome in infants and neonates. Okay? So one has to be careful in prescribing such drugs to infants and neonates. Let's take another clinically very important example. So the first one that we talked about was chloramphenicol. Okay. So where did we start? All right. So this is the first drug. Let's take the second drug. And the second drug that is important is which drug? Second drug is which drug shall we take? Let's take sulfonamides. Okay, so sulfonamides in the same patient population, the neonates and infants, it can cause a disease. Which disease are we talking about? It can cause Kernicterus. Okay, so what is Kernicterus? It is basically brain damage due to deposition of bilirubin in the neurons. Okay. So to understand why sulfonamides cause Kernicterus, we need to look at the metabolism of bilirubin. So the story begins in the bone marrow, which produces reticulocytes, which gives rise to mature RBCs. And these mature RBCs are carried in the blood vessels. Okay, those are the mature RBCs. Now, these RBCs travel throughout the body, the blood vessels, and they lose their membrane integrity in about 120 days. Their membrane becomes compromised. Then what happens? They are taken up by the phagocytic cells. Okay, where in the spleen or in the blood or in the liver. Okay, these phagocytic cells, what do? They degrade the RBC. Okay, so the membrane gets lost, and inside the RBC, what do we have? We have hemoglobin. Now this hemoglobin is degraded to heme and globin. Globin is a protein, and this protein is recycled. Okay, this heme, from the heme, the iron part is again recycled, and this heme is degraded into bilirubin. Okay, this bilirubin goes into the blood. Okay, maybe in the blood vessel, and this bilirubin, it is highly lipid soluble. Okay, this bilirubin is lipid soluble, and this is, let's take another color. Okay, so let us consider this bilirubin, and this bilirubin is carried by the plasma protein albumin. Okay, so this complex of albumin and bilirubin inside the blood, we call this unconjugated bilirubin. Okay. So this combination is now carried to the liver. And what does the liver do? The liver again uses the same enzyme, UDP, glucuronide transferase. Okay, and transfers what? A glucuronide group to bilirubin. Okay, so now it becomes conjugated bilirubin. Okay, so bilirubin with glucuronide group. Okay, so that is called as conjugated bilirubin. This conjugated bilirubin is excreted through the bile. It reaches into the intestine, and the intestinal bacteria convert the bile to, the conjugated bilirubin is converted to urobilinogen. Okay, it is again degraded into stercobilin. Okay, and this gives the color to feces. Okay. part of this urobilin is reabsorbed into the liver, okay, and it is transported into blood, and it is in this process it is converted into urobilin, and this urobilin colors urine. Okay. So this is the metabolic pathway of bilirubin. Okay, so why are we talking about all this? Is that in the blood vessel, there is unconjugated bilirubin. What is that? Bilirubin plus albumin. Okay. So there is unconjugated bilirubin. Okay, in the infant or the child. Okay, so now into this patient we are giving sulfonamide. So what happens is this sulfonamide goes and binds to the binding site which was previously holding bilirubin. So now what we will get is albumin plus sulfonamide. Okay, we will get this in the blood plus free bilirubin. This free bilirubin is highly lipophilic. It will cross the BBB. It will get deposited in the neurons, and that we call Kernicterus. Okay, again, this is the second drug that we are talking about, which is clinically significant in neonates and premature infants. Okay, so let us consider another case here, another thing related to the age in elderly people. In the elderly clients or patients, in elderly clients, they have got decreased renal function. Okay, so if there is a drug that is renally excreted, then the dose should be adjusted in the elderly people. Okay, so what are we now talking about? We are talking about the patient factors that should be considered for selecting the drug therapy. Okay, so we have looked at one factor, which was age. Let's look at the second factor that we are going to consider. Let's call it second is, let's zoom it up. For some reason it's getting slow. Okay, the second factor that we would look at is renal disease. Okay, so if the patient has got renal problem and say that patient is given a drug called vancomycin. Do you remember vancomycin? We talked about it is given for which disease? MRSA, very good. Right. So this vancomycin itself is nephrotoxic. So if this drug is given to a person with renal disease, then it might not be the best drug. Okay. So we the patient should be assessed for renal disease before a drug is selected. Let's look at another patient factor, third. Say hepatic disease. Okay, so antibiotics like tetracyclines and erythromycins. Okay, so these drugs are contraindicated in a patient with hepatic disease. So if you want to select a drug in a patient with hepatic disease, some antibiotics cannot be selected. Okay, let's look at another patient factor. Okay, say pregnancy. So if a patient is pregnant, there are some antibiotics which may be teratogenic. Okay, what is teratogenicity? Teratogenicity is if the drug causes any structural or functional defects in the child after in utero exposure. Okay, so when the mother is pregnant, you give some drug, and that drug produces structural or functional defects and which is observed after the child is born. Then that drug which produced that is called teratogenic. So certain antibiotics are teratogenic, like tetracyclines, chloramphenicol, sulfonamides. Okay, so these drugs are teratogenic, so they are not the ideal drug that should be given to a patient who is pregnant. Okay, so what are the safe drugs then? Are there any safe drugs that can be given in pregnancy? The relatively safe drugs are penicillins, cephalosporins, erythromycin, clindamycin. Okay, so these drugs are relatively safe. They are not found to be teratogenic, and therefore they can be given if the patient is pregnant. The other patient condition that we can consider is if the patient is lactating. Okay, lactation. Okay, so after the mother has given birth and the mother is suckling the child, then if the antibiotic that we select is lipophilic, then the chances are that it will be transferred to the suckling infant, and that can cause problems in the infant. Okay, so drugs like metronidazole, so quinolones. Okay, so these drugs, they should not be administered to a mother who is lactating. So then what are the safe drugs then which can be given to lactating mothers? Okay, the relatively safe drugs would be aminoglycosides. Amoxicillin, anti-TB drugs. Okay, so drugs against tuberculosis, cephalosporins, macrolides, and trimethoprim, sulfamethoxazole can be given. Okay, so these drugs are relatively safe in a lactating mother. Okay. Okay, let us look at another patient's status. Okay, let's look at 6. 6 could be immune status. Okay. Allergy should be noted. Okay, so if the patient is allergic to penicillin, okay, so there are many patients who are allergic to penicillin. That can be a problem. So what should be done? Intradermal skin tests should be done before administering the drug. The other thing that is important is bacteriostatic drugs. Okay, so bacteriostatic drugs should not be given to immunocompromised patients. Immunocompromised clients. Okay, who are immunocompromised? Say patients with HIV or who have undergone organ transplantation. Okay, in such people, we should not administer bacteriostatic drugs, because what the bacteriostatic drugs do is they stop the bacteria from dividing, and the immune system then gets rid of the bacteria which are not growing. But if the patient is immunocompromised, then the immune system cannot clear it. Okay, so the immune status is important. Okay, so where are we in our scheme? We have basically talked about 3 aspects. Okay, so what are we talking about? We are talking about how to select a drug. What are the general principles in selecting a drug for antimicrobial chemotherapy? Okay. All right. So based on all these factors, we select a drug for empirical therapy. Okay. By this time, we have to remember we have now given the specimen for culture. Okay, so before we get the result for culture and sensitivity, we have started the empirical therapy. Okay, so we are going to get the result of the culture after we have instituted the empirical therapy. So now the patient is already getting the empirical therapy. So now what we have to do, we have to assess the drug that we have given for efficacy and toxicity. Okay, so we continue to observe the patient and the response of the patient. Okay, and when we observe, we know whether there is any toxicity. Okay, so that is what we are doing. All right. So now what the last step is, refine the instituted therapy. So now we have given the therapy, we are now observing the patient for toxicity, and we find that there is no toxicity, but now we have got the result of the culture, we have obtained the result of the culture and sensitivity. Okay, so now we know which antibiotic is the best for the person. So now what we do, we refine the instituted therapy based on the result of the culture and sensitivity. So what do? We refine the therapy and we give a drug which has got maximum sensitivity, narrowest spectrum, and the drug with the least cost. Okay, so this is how we refine the instituted therapy. It is based on the results of the culture and sensitivity. So this technically, when we do this, when we change the empirical therapy with a drug with maximum sensitivity, narrowest spectrum, and least cost, we call this de-escalation. De-escalation of the instituted therapy. Okay, so these are the 5 stages which are involved in the which should be followed ideally in a drug selection process. Okay. Drug selection process. Okay. All right. So now what we have to do, we have given the drug, we have refined we have de-escalated the therapy. Now what we have to do is, the patient, as a healthcare provider, we should counsel the patient. Sell the patient or our client. Okay, what should be counsel? We should say the patient should continue the therapy for the prescribed time, even if the client has become better. Okay, so they have to adhere to the direction. Okay, so all in all, the healthcare provider should ensure the right patient is treated with the right drug, is treated with the right drug. Okay. In the right dose, okay, by the right route the right route of administration for the right duration. Okay, for the right duration. Okay, the 5 right. The right patient should be given the right drug in the right dose through the right route for the right duration of. So if we do this, what is the payoff? The healthcare provider can ensure antimicrobial stewardship. Okay, so if the healthcare provider ensures antimicrobial stewardship, what will it do? It will benefit the patient or the client. It will benefit the client, and it will reduce the resistance. Okay, all in all, it will make the society better. Okay. So in this lecture, we have tried to cover the clinical aspects of the general principles of antimicrobial chemotherapy.